In this video, I will be discussing one of the common procedures that I perform as a functional neurosurgeon, which is deep brain stimulation. Deep brain stimulation is the delivery of a small amount of current through an electrode that's placed in the brain in order to decrease symptoms. These symptoms can be things like tremor from a movement disorder, such as Parkinson's disease or essential tremor. It can also help decrease dystonia. It can also decrease the number of seizures in epilepsy patients, and it's also being used now for neuropsychiatric indications such as depression and obsessive compulsive disorder, or OCD. The latter two are more on a trial basis, and you'll be referred to me by your psychologist if they think that you're an appropriate candidate. If you're getting deep brain stimulation for a movement disorder, such as Parkinson's disease, essential tremor, or dystonia, then you'll be referred to me by your movement disorders neurologist. If you're getting deep brain stimulation for something like epilepsy or a seizure disorder, you'll be referred to me by your neuroepileptologist. Once your neurologist, whether it's an epilepsy neurologist, a movement disorders neurologist, or your psychologist, decide that you're a candidate for surgery, they will refer you to me and we will have a surgical meeting. Our first surgical meeting will be to discuss any general questions that you have about surgery. I ask that you watch this video prior to coming to this meeting and write down any questions that you have so that we can answer them at this first meeting. After this first meeting, I'll have you go home and think about whether or not surgery is the right thing for you. If you decide to move forward with surgery, we will meet again. Our second appointment before surgery will be to address any last-minute questions that you have, and also for you to sign any paperwork prior to the day of surgery. We will also have you visit our anesthesia colleagues for any preoperative information that you may need. This information includes what medications to take on the night before your surgery, what medications to take on the day of your surgery, and when to stop eating or drinking the night before your surgery. In general, I prefer that all patients who are going to have surgery with me stop eating or drinking at 10 p.m. the night before surgery. The strict deadline is midnight the night before surgery. However, if you can stop at 10 p.m. the night before, there is a small added benefit. The main reason we don't want you to eat or drink anything the night before surgery is because any contents that are left in your stomach, whether it's food or liquid, can potentially go up your esophagus and into your airway, like your lungs or your trachea, and cause an infection during surgery when you're sleepy. This can lead to something like a pneumonia, which we would then have to treat. In order to avoid this event, this aspiration, from occurring, we ask that you don't eat or drink before surgery. I ask that you please go ahead and provide me in clinic when I see you with the name of your surgical point of contact, meaning the person who's going to be with you for the day of surgery, and that you also provide me with their phone number so that I can reach them easily on the day of surgery. I will provide them updates as soon as the case is done with how everything went. Before all of my surgeries, I also ask that you have any chronic conditions such as diabetes and hypertension or high blood pressure under good control. If you have a history of diabetes, I ask that your HbA1c, which is a measure of the amount of sugar you have in your body, be less than 6.5. If it's higher than this, there is a very high risk of infection to the device. If a device gets infected, we will have to remove part or all of the device, in which case it will not be effective for at least a period of 6 to 9 months until we can reimplant the device. During this period of time, you will need to be treated with a long course of antibiotics in order to clear the bacteria from your system. Once the bacteria is cleared, we can go ahead and implant a new device. We'll be getting lab tests at about 6 months and 9 months out to ensure that the infection, as far as we can tell, has cleared. During this period of time, you also will not have stimulation to the device, and so any symptoms that the device was helping with will no longer be treated the same way. You may have to go back on your medication or to higher doses of your medication in order to help control these symptoms again. If you have high blood pressure, I would like you to get that under control with your primary care physician before surgery. If you have difficulties with significant obesity, I will also need that addressed prior to surgery. I place a frame on patients in order to stabilize their head during surgery and for patients who are obese, it can be very difficult and somewhat dangerous to place this frame. I need your BMI to be less than 35 in order to proceed with surgery. Whether you achieve this with lifestyle modifications, dietary modifications, or with medications, you can discuss that with your primary care provider prior to seeing me in clinic. If you've had surgery in an area where you think we might be operating on, it's very important to let me know this in clinic. If you've also had infections from a prior surgery, please let me know in clinic. This can increase your risk of infection for any surgeries that you have in the future, especially any brain surgery. If you have other pre-existing conditions, we might need clearance from one of your doctors in order to proceed with surgery. If you're on blood thinners prescribed from one of your other doctors, especially a cardiologist, we'll need clearance from them to stop the medication 7 days prior to surgery and 7 days after your last surgery so that we can go ahead and safely implant the device. If you've had any radiation to your chest or neck or any systemic chemotherapy, this can increase your risk of wound healing issues and your risk of infection. I ask that you please alert me about this in our clinic appointment. I also ask you to let me know if you have any skin conditions on one side of your head or the other on the scalp or on your chest. This can also increase your risk of infection if a device is placed. Please also let me know if you use any topical steroids, as this can decrease the amount of wound healing and lead to wound breakdown after surgery. We will want you to hold any use of topical steroids or oral steroids during the recovery period. You can usually restart these medications after 4 weeks, unless they are deemed absolutely necessary by your dermatologist or another physician. My operative days are primarily Mondays for my larger cases. On Fridays, I go to Callahan Eye Hospital, where I place second stage batteries for deep brain stimulation, and I also place batteries that have run out of charge for deep brain stimulation as well. For Parkinson's disease, there are several different types of symptoms that can be treated with deep brain stimulation, medication, or with focused ultrasound. We will discuss primarily deep brain stimulation in this video. The primary symptoms that most Parkinson's patients have are a resting tremor, which means when they're not utilizing their hands or their legs, they have a tremor. Bradykinesia, which is slowed movements or slowness of movements. And rigidity, which is stiffness of movements. For Parkinson's disease, DBS is expected to significantly reduce your Parkinson's motor symptoms or slowness of movement, rigidity, and tremor, as well as the amount of off medication time that you have. It can also help decrease dystonia and dyskinesias, or unwanted abnormal movements, but may not entirely eliminate them even with the most optimal program settings. DBS may not be expected to improve symptoms such as balance problems, freezing of gait, speech difficulties, or any non-motor symptoms that you might have, such as dysautonomia, or difficulty with regulating your autonomic nervous system, constipation, sweating, or abnormal difficulties with sleep. The main risk of deep brain stimulation surgery includes a 1 to 2% risk of stroke or hemorrhage and a 1 to 2% risk of infection that might require hardware removal. On the day of surgery, I ask that you do not take your Parkinson's medications so that we can actually evaluate your tremor at the time of surgery. If you are an epilepsy patient, please take your morning epilepsy medications before surgery. That means as soon as you wake up in the morning. Even if you usually take your medication at 7 a.m. or 9 a.m. or some other time in the morning, please take them first thing in the morning with a very small sip of water so that we can ensure that you don't have any seizures during the surgery itself. Specifically, I want to be able to test your symptoms in the operating room before and after lead placement as a way to ensure that we've gotten to the appropriate location in your brain. The placement of the deep brain stimulator is done in 2 stages. The first stage is done on a Monday, and the second stage is done on a Friday. I will discuss each of these stages. While the first surgery is done at the UAB main hospital, the second surgery is done at the Callahan Eye Hospital, which is close by. The first stage, on Monday, is the placement of the intracranial leads or electrodes. These electrodes will either be placed on both sides in order to address both sides of your body, or they will be placed on one side to address the opposite side of your body. There are pros and cons of placing bilateral leads if you have bilateral symptoms. On the one hand, there is a small amount of edema or swelling that occurs from the placement of any lead into the brain. If you have two leads that are placed at the same time, you might have an increased amount of swelling from these two lead placements. If you're somebody who already has difficulties with impulsivity or mood disorders such as depression, these can worsen with the placement of two electrodes placed at the same time. Your neuropsychologist will evaluate you and determine whether or not you'll be a good candidate for placement of two leads at the same time if you have bilateral symptoms, meaning symptoms on both sides of your body, the right side and the left side. If you are a swimmer or you swim frequently, please also let me know at the clinic appointment, as bilateral deep brain stimulation in very rare cases can cause difficulties with swimmers. If you only have symptoms on one side of your body, say the right side of your body, then we only need to place one electrode on the opposite side of your body, meaning your left brain to control your right body. If you want your left body to be addressed, then we would place an electrode on the right side of your brain. If you really only have symptoms on one side of your body, we'll usually plan on placing the battery on the same side that we place the electrode. The electrode, again, gets placed on the top of the head, around here, a couple of finger breadths behind the hairline. You will have another small incision behind the ear, and you will have one incision on the chest where the battery is placed. There are two different general types of batteries that can be used. There are rechargeable and non-rechargeable batteries. The default battery that we tend to use for most patients are the non-rechargeable batteries. These days, they have a very good battery life, and they also are very low maintenance for the patient. Non-rechargeable batteries tend to need to be replaced on average about every 3 to 7 years, depending on what your settings are for your deep brain stimulator. When it comes time to replace the battery, we only need to open up the small incision on your chest, replace the battery, and take out the old one. This procedure usually only takes about 20 minutes, is also done as an outpatient same-day surgery at Callahan, and usually only requires the use of minimal sedation or in some cases no sedation and just significant local anesthesia that's placed at the wound site. These surgeries are quick and very well tolerated. Most patients have very little pain after these battery replacement surgeries, and they only require Tylenol. Non-rechargeable batteries are what I would call set and forget. Between the time of the placement of the battery and the replacement of the battery, you do not need to do anything with these batteries. You will be seen, however, by your neurologist about once every 6 to 12 months, even after the optimal settings on your DBS have been programmed, just in order to ensure that you still have significant battery life left on your device. If they notice that your battery life is running low, they will alert me, and my office can go ahead and set up a date to replace the battery. This usually does not take very long to get scheduled. Myself or one of my excellent colleagues in the functional department can go ahead and replace this battery if I'm not immediately available. Please let my office know if you would like me or the first available provider to go ahead and do your battery change at that time. Rechargeable batteries, on the other hand, do take a little bit of maintenance. Rechargeable batteries do need to be recharged about once every week to once every 4 weeks, depending on how much energy your deep brain stimulator is drawing from your battery. This will be dependent on the settings of your deep brain stimulator device, which will be determined with your neurologist. The upside of a rechargeable battery is that they're often lower profile, meaning that they have a smaller width to them, so they're not as readily seen on the chest wall. So for skinnier patients, this can be a good option. It's also a good option for younger patients who are used to charging multiple devices in their daily living. The other reason this can be an advantageous device is because it doesn't require as frequent battery changes throughout one's lifespan. The other benefit of a rechargeable device for a patient who has a long lifespan ahead of them is that they require less battery changes because they have a longer lifespan. Rechargeable devices usually can last about 10 to 12 years, whereas the non-rechargeable devices usually require more frequent changes. Overall, I would recommend the rechargeable device for any patients who are very thin or who are very young and very high functioning and can fit in the weekly to monthly charging into their routine. We use 3 different manufacturers of deep brain stimulation devices here at UAB. Which device is used will be discussed with your neurologist and ultimately decided by them. From the surgical standpoint, there's very little difference between the surgical workflow for these devices. Another benefit to having 2 separate batteries, if you have 2 separate leads, is that you can have the batteries drained at a slower rate. No longer have 2 leads drawing power from the same battery, and instead you have 1 lead drawing power from each single battery. This can potentially lead to a decrease in the number of battery exchanges that you need over your lifetime. Between your first and second appointments, I will discuss your case with your neurologist and your neuropsychologist in order to determine what the best target is for your case, and also if we should implant one side or both sides, and if we should do it all at once or in a staged fashion, meaning placing one side and then waiting several months before placing the other. We will also discuss, if you're getting both sides placed, whether it makes sense to place 2 completely separate systems, meaning a lead and a battery on one side and a lead and a battery on the other side, or if we should place both leads and tunnel them both to the same battery on one side of the chest. Reasons why it might be good to place 1 battery instead of 2 if you're having 2 leads placed is if you have surgery that's already occurred on one side of the chest or the other, including the placement of a pacemaker or a port. It also might be a good idea to place only 1 battery if you have a history of infection on one side of your chest or the other, or if you have a skin condition on one side of your chest or the other. One other reason why it might make sense to place only 1 battery instead of 2 if you're having 2 leads placed is if you're a marksman and you holster your rifle on one side of your chest or the other. I do not want you to holster your gun on your chest if you have a battery that is implanted there. This can significantly disrupt or even destroy the implanted deep brain stimulator device, causing it to be ineffective. One reason why it might be good to have 2 batteries placed instead of a single battery if you're having 2 leads placed is because you can go ahead and have 2 completely separate systems. The reason that this is helpful is if you are an older patient, you've had previous infections before from surgeries, and you think you'd be likely very prone to an infection of a surgically implanted device, then we have 2 completely separate systems so that if one side gets infected, the other side is not affected. Therefore, if one side gets infected, we only have to remove 1 system, meaning only 1/2 of the body will no longer be receiving therapy. If both systems are plugged into the same battery, we will have to go ahead and remove the entire system from both sides, meaning that both sides of the body will no longer have therapeutic deep brain stimulation. If we are planning to place 2 leads, but we decide that it might not be a good idea to place both leads at the same surgery, what I can do is I can place 2 extension or connection wires from the scalp down to the chest so that we do not have to do that second stage twice. For the stage 1 placement of the electrodes, I do not need to do a large head shave. I will have to shave a patch of hair on the top of the head, usually about this big, in order to place one of the electrodes. If we place 2 electrodes, I'll have to do that on either side of the head. I usually like to leave a little bit of your hairline hair in place so that you still have some hair that can be visible if you're wearing something like a hat to cover up your incisions. To repeat, I do not have to shave your whole head in order to do this surgery. The first surgery, which will be done on a Monday, will be an awake surgery if you're getting it placed for Parkinson's disease or essential tremor. If you're getting DBS placed for epilepsy, it will be done asleep. For patients who are undergoing deep brain stimulation for Parkinson's disease or essential tremor, the reason that we do this awake is because it allows me to test your symptoms before and after placement of the lead so that I can determine that I'm in a very good spot for you. We go ahead and do test stimulation during the procedure so that we can determine one, efficacy of the deep brain stimulator, and two, any side effects that you might be experiencing. This helps me determine if the lead is in an appropriate spot in the brain or if it needs to be slightly positioned in one direction or the other. When I say that this will be an awake surgery, I do not mean that the entire surgery will be done awake. If you are undergoing an awake DBS surgery, you'll only be fully awake during intraoperative testing, which is about 30 to 40 minutes of the procedure. The rest of the time, you'll be under what we call twilight sedation, which is similar to what you get for a colonoscopy. During this period of time, your pain will be controlled and you likely won't remember most of the events from the surgery. During this period of time, I place your head in a head frame in order to keep your head still. We place a Foley catheter in order to help you urinate during the surgery. And we also go ahead and place a large CT scanner around your head during the surgery so that we can take scans during the surgical procedure. From this point on, you will stay pretty sleepy while I go ahead and determine the exact trajectory that we will take to go ahead and place this electrode into your brain. I will drill out a small nickel-sized piece of skull in order to go ahead and place the electrode and the cap that secures the electrode. Once I have completed the drilling and I have partially placed the electrode, you will be woken up fully. At this point, we'll go ahead and do intraoperative testing. We will ask you to go ahead and do a variety of tasks, including moving your hands and a variety of verbal tasks. There is also an option for patients with Parkinson's disease, essential tremor, or other movement disorders such as dystonia or other types of tremors to have deep brain stimulation done fully asleep as well. However, I suggest that you only do this if you have issues with severe anxiety and you think that you might have significant difficulties with performing the small tasks that we ask you to do in the operating room. If we were to do this surgery for a patient with a movement disorder fully asleep, then we could do this in the MRI scanner. In the MRI scanner, we would be able to tell exactly where we've placed the lead and confirm that it's in the appropriate structure. However, we wouldn't be able to test the lead placement on you and determine whether or not you specifically are having any side effects or any benefits from the placement of the lead. That's why we generally prefer to do these awake if possible so that we can test the efficacy of the device and also for any side effects at the time of surgery and readjust as needed. While most people do very well with placement of the lead in a very specific part of the brain, either the subthalamic nucleus or the globus pallidus interna for Parkinson's disease, or the VIM, the ventral intermediate nucleus of the thalamus for patients with essential tremor, or again, the STN or GPI for patients with dystonia, everybody is a little bit different. And just because we're placing it in the appropriate anatomic portion of the brain does not necessarily mean you will have your most optimal results unless we can actually test it in the OR. It gives us a slight additional advantage to being done completely asleep. For patients who are undergoing this for epilepsy, there is nothing to test, unfortunately, in the operating room, so there is no reason for them to be awake for these procedures. We also have the opportunity for you to be engaged in research. If you'd like to be involved in any research protocols, this adds on only about 15 to 20 minutes of time in the operating room and can help other patients in the future. It'll not change anything about your care. If you're interested in getting involved in any sort of research projects, please let me know during our clinic appointment. After we've done intraoperative testing, I will take an image of your head, a very quick low-resolution head CT, in order to confirm that the electrode looks like it's in the position that we want it to be in. Once we've confirmed on imaging and with testing that the electrode is in the appropriate spot, I will go ahead and anchor it with a clip that will be placed on the skull in order to keep the electrode in place. We will get you sleepy again, and we'll go ahead and close up the incision. We coil the excess amount of the lead that will later be connected to the lead extender underneath the scalp. Sometimes you can have some pain after this portion of the surgery, which usually is a scalp pain and goes away in about 1 to 2 days. However, You will not be very awake for this portion of the procedure and likely will not remember any of that part of the procedure. By the time you're fully awake, we will have your head out of the head holder and you'll find yourself either on the bed in the operating room or in the post-anesthetic care unit, or the PACU for short, where you will go for recovery. The frame that I use to keep in place will leave 2 small marks on your forehead where the pin sites are, usually about here and about here. You might notice that there's a small suture or piece of tape covering these small marks above your eyebrows. This piece of tape can be taken off 2 days later, and the suture, if placed, is absorbable and will fall out on its own. If it does not come out by the time of a follow-up surgery where you're having your stage 2 battery placed, we can go ahead and snip it at that time. These 2 small incisions usually heal up very well within the first week or so, and you do not notice them in the long run. You usually stay in the recovery area for about 3 to 4 hours. While you're in the recovery area, I will get a high-resolution head CT. This high-resolution head CT will allow me to see if there's been any small bleeds with the placement of the electrode. As mentioned before, there's a low likelihood of a risk for bleed during this procedure. The planning for these electrode trajectories is done on image-guided software, which allows me to see most of the vessels in the brain. There is a chance that there are very small vessels that are not visible on imaging, and this would be the case where there might be a very small punctate bleed on the head CT. If this is a case, it usually does not cause any symptoms. Even if there's a slightly larger bleed, most of the symptoms usually resolve within a couple of weeks. Some patients can have chronic symptoms from a large bleed. The chance of a large bleed occurring is about 1 in 1,000 and is very rare. In these cases, patients might experience symptoms such as difficulties with moving half of their body, difficulties with feeling sensation on half of their body, or even difficulties with seizures or speech. If a patient develops seizures, we can start them on anti-seizure medication and slowly wean them off over the course of several weeks if it seems like they don't have any ongoing issues. Oftentimes, if a patient does have seizures after surgery like this, it'll be a one-time thing and it will self-resolve thereafter. In very rare cases, it becomes a chronic issue, in which case we will have you follow very closely with an epilepsy neurologist who can help manage this for you using medications. If for any reason your leads ever need to be removed, as in cases of infection, then all of these same risks also apply to that surgery as well. If I see any bleed on the head CT, I will let you or your point of contact know. If, as in a majority of cases, there is no bleed, then the patient will be transferred to the floor where they will remain for the rest of the night. Most patients only need to stay 1 to 2 nights in the hospital, meaning you'll be discharged on a Tuesday or a Wednesday if you underwent surgery on a Monday. You will need someone to take you home from the hospital after both surgeries. You cannot drive yourself after surgery, and you also cannot drive yourself while you're on narcotic medications. Once you're admitted to the hospital, my resident team will be taking care of you, and I will be seeing you as well to ensure that care is going smoothly. During this period of time, we make sure that you can get back to your normal activities. This includes things like tolerating food and water, being able to get up and walk around, and also being able to tolerate any headache that you might have after surgery. I would expect to have about a 3 to 7 out of 10 headache after surgery. Most people are able to control their pain with a little bit of narcotics on the first day and primarily Tylenol thereafter. You will receive all the pain medications that you need for both surgeries after your discharge from the hospital from the first staged surgery. I ask that when you go home, that you continue to take Tylenol every 6 hours if it's within the first 3 days of surgery. This is going to help with inflammation and with any pain that you have. We will give you a small amount of narcotics to take home that you can take orally if you're having any severe breakthrough pain. But for most of my patients who have movement disorders or epilepsy disorders, I generally don't like you to be on large amounts of narcotics, as this can lead to sleepiness, grogginess, imbalance with your gait, and therefore lead to falls and damage to the device or potential injury to your head. It can also lead to severe constipation as well, which can increase the amount of pressure that you have in your head as you try to bear down when going to the bathroom. These are all issues that I like to try and avoid by staying on a good non-narcotic regimen. Again, Tylenol is the best thing to take within the first week of surgery. After the first week of surgery, you can add in other types of over-the-counter pain medication, including NSAIDs, or non-steroidal anti-inflammatory drugs, such as ibuprofen or Motrin or naproxen. Again, please do not take any NSAIDs within the first week, as this can slightly increase your risk of bleeding during this time. And we recommend that you take regular Tylenol for the first 3 days at least after both surgeries. After you're discharged from your stage 1 surgery where the leads are placed, you will come back for a second stage surgery on Friday. The second surgery only takes about an hour and a half. This surgery will require a small second incision, usually right behind the ear, as well as another incision that will be placed on the chest for the placement of the battery. The incision on the chest will be placed about 2 finger breadths below the collarbone, and the battery will be placed on top of the muscle and underneath the skin. The second surgery is done under general anesthesia. A tube will be placed into your mouth to help you breathe, and you will be put fully asleep. I like to tell patients that the second stage is actually more painful generally than the first stage. This is because we have to tunnel the electrode lead extender from the top of the skull through the neck to the chest. We go ahead and tunnel this under the skin above the muscle, but sometimes it can irritate the muscle and cause either headaches or cramps in the neck, which can be painful. It is okay to gently touch or massage the neck after the surgery has been completed. You can ice it, or you can apply a small amount of heat to it if you feel like that helps. You might notice a little bit of soreness of your throat after the surgery because of the tube placement. This is very normal and usually resolves within a couple of days. It is okay to take things like lozenges in order to soothe your throat after surgery. The entire device should remain inside of the body underneath the skin, and no part of the device should be visible at any time. Sometimes, when the swelling has gone down after surgery a few weeks later, some patients will notice that they will see either the device more clearly outlined on their chest, the lead extender that's running down their neck as a small spaghetti string, or they might even notice the small bump from the cap on the top of their scalp. This is all very normal to see, and the lower your body weight, the more visible the device may be. In general, if you have any concerns about erosion of the device through the skin, please let me know as soon as possible and come see me in clinic. If the device does erode through the skin, or if the incisions do not heal properly, this can cause a major infection of the device and of the brain. The most common site for device infection is actually the battery site. If you notice any redness, tenderness, or new swelling that occurs at the battery site, or any expression of pus, please let my office know immediately and come see me in clinic as soon as possible. Once the entire system is placed, this is just the beginning of your journey. You'll come back and you'll see me or somebody from my clinic in about 2 weeks after the surgery. At this time, we'll do an incision check. We'll remove the staples that are placed in the incision on your scalp, and we'll check the absorbable sutures that are placed on the incision of your chest. Staples will be used to close the small incision behind your ear on your scalp, and absorbable sutures will be placed on the incision on your chest. The staples will be removed 2 weeks after this surgery at the same time that the staples from your other head incisions will be removed. The absorbable sutures on your chest will dissolve on their own. This incision will be checked at the 2-week mark. You will also have small steri strips, which are sticky pieces of tape that are placed over the incision to help protect it. You'll also have a large bandage that's placed over these sticky pieces of tape. The large bandage can be removed from all of your surgical incisions 3 days after your surgery. Please do not get the incisions wet for these first 3 days. If you want a sponge bath or shower on the rest of your body, that is okay. Once these 3 days pass, you are welcome to go ahead and lightly shower on your head or your body, letting the water just drip over these incisions. Please do not scrub dry any of the incisions. Simply pat dry any of the incisions on your head or on your chest. You'll notice in the shower that the small sticky pieces of tape that are placed over the chest incision will slowly start to come off. Allow these to come off on their own. Do not rip them off, as this can open the incision. After 2 weeks, if these have not fallen off on their own, you can wet them and slowly take them off yourself, or we can remove them in clinic at our 2-week follow-up appointment. Do not apply any ointment to any of the incisions. Leave them clean and dry. You might notice a small amount of scabbing at the incision sites on your head. That is very normal. You can gently try to wash some of it off starting 7 days after surgery, but do not aggressively remove it. If it does not easily wash off on its own, do not force it. Do not submerge your body in a bath, a pool, or any standing water for 2 weeks following surgery. This will allow all of your incisions to properly heal. Once the staples are removed, there will be some small holes that are left behind. I do not want you to shower on your head for 2 days following staple removal to allow these small holes to heal. After the second stage surgery, when you go home, you might notice a small amount of bruising along the neck or the chest from where the lead has been tunneled. This is normal. If you want to apply an ice pack or a heat pack to the area, that is okay. Just make sure that it is a moderate temperature and not very hot and not very cold. You'll also see me 3 months after surgery in order to ensure that your care is progressing well. If you have any concerns about the surgical sites between the 2-week mark and the 3-month mark, please reach out to my office and let me know. If you see any new signs of redness, swelling, fluid coming from any of the incisions, or pus, these could all be signs of infection. Please call my office and alert me immediately. If you see any protrusion of the device through the skin or non-healing incisions, also please alert my office immediately. If you notice significant swelling at the site of the battery or bruising that continues to grow 3 days after the surgery, please alert my office. If you notice that it is swelling to a point that the incision itself is starting to get compromised, please let my office know. Once we are done with the surgery, you will still have the Foley catheter in place. This gets removed the first morning after surgery. We leave it in place overnight so that you don't feel like you have to run to the bathroom. If you do want it removed that evening, you're welcome to have the nurses remove it. After surgery, once you're awake enough, you can go ahead and eat and drink a normal diet. Some patients note after the placement of the initial lead that they have something called the microlesioning effect or the honeymoon effect. What this refers to is a temporary reduction or removal of all of their Parkinson's symptoms, specifically their tremor, rigidity, and bradykinesia after placement of the lead without a battery being placed and without the stimulator being turned on. This phenomenon happens in some patients and does not happen in all patients. If you have the honeymoon effect for Parkinson's disease or essential tremor, it's a good indication that we're in a good spot for your symptoms moving forward in the future. If you do not have the honeymoon effect or the microlesioning effect, it does not mean that you're in a bad spot. We currently do not know why some people have this effect and others don't. But if you don't have this effect, that is not a negative prognostic indicator. In fact, you can still have very good stimulation effect even without the honeymoon effect having occurred right after surgery. Once the battery is placed, we will turn on a very small amount of power to the battery. However, it might not be enough for you to notice any symptom relief. The battery will need to be programmed over the course of 3 to 9 months with your neurologist. This can take some time to optimize the programming settings. During this period of time, it's very important for you to keep track of which programming settings you're using and if you're having any benefits or side effects from the deep brain stimulator. If you and your neurologist are able to find good settings for your deep brain stimulator, There is no need to follow up with me in clinic unless you find that you're having any difficulties with the surgical incisions or if you're interested in a second stage surgery if you only had one side placed. If you're unable to find good settings, it could be an issue with placement of the lead. If this is the case and your neurologist has high concern for this, they will reach out to me and discuss whether or not we should revise the lead placement. If this is the case, you will come and see me in clinic and we can discuss this further. Usually, if we have good intraoperative testing, however, this is a good sign that you're in a good spot for long-term programming of your device.